Welcome. Welcome to this side event. It is indeed our privilege to host this science, technology, and innovation side event on introduction of artificial intelligence, our acronym AI, and how it is being used in health, education, and other sectors. We have very talented groups of speakers and experts on this panel today who will present various aspects of utilization of AI in our daily lives. AI's benefits and pitfalls will be explained. If you have questions for our panel, please feel free to contact them directly. Their email addresses is written on speaker's name and meet the speaker, or write it in the chat box. Let's get started. All right. And share. I think I'm doing it well. Here it is. All right. As we all know, the future of health and education sector is digital. AI literacy to the public on all levels in all countries in order to empower people and reduce the digital divide is essential. AI is not a big bad wolf or a monster. All UN member states should work with international organizations, NGOs, education and health sectors to provide AI literacy. Women's Health and Education Center aims to enable stakeholders to take shared responsibility based on a global and intercultural dialogue. We hope this side event promotes multi-stakeholder, multidisciplinary, and pluralistic dialogue and holistic building about ethical issues relating to AI systems. We hope our efforts will contribute to promote equitable access to developments and knowledge in the field of AI and sharing of benefits with particular attention to the needs and contributions of low and middle income countries, including the least developed countries, identified by the United Nations Development Program, UNDP. We aim to ensure that national AI strategies are guided by ethical principles. Now, what is AI? According to National Institute of Health, NIH, their definition is AI is a science and a set of computational technologies that are inspired by, but typically operate quite differently from, the ways people use their nervous systems and bodies to sense, learn, reason, and take action. A specific definition of AI by OECD, Economic Cooperation and Development, is an AI system is a machine-based system that can, for a given set of human-defined objectives, make predictions, recommendations, or decision influencing real or virtual environments. AI systems are designed to operate with varying levels of autonomy. Machine learning is a process by which machines can be given the capability to learn about a given data set without being specifically programmed on what to learn. Machines are usually learn in either a supervised or unsupervised manner. The machine can use to infer hidden qualities of the data and distinguish the categories from each other. It is then able to use this knowledge to work on the test data and make informed predictions. That is, who is in this population are likely to develop coronary artery disease. Now, deep learning is a relatively modern technique used to implement machine learning. A deep learning algorithm takes a data set and finds patterns and critical information by imitating how a human brain's neurons interact with each other. Algorithms are artificial neural networks, a computing system that simulates the brain's ability to weigh the importance of some data versus others and handle bias. Now, artificial intelligence, the focus of my presentation today is on health sector. AI chatbots, which are in use in health sector and our experience with it. Chat GPT is most commonly used in health sector, and it was released for public use in November 2022. Its rapid adoption has raised questions about capabilities, limitations, and risks. This presentation and discussion is mostly highlights the current state of Chat GPT technology for the medical field. There are other AI chatbots like from Google, Bard, and Microsoft's Bing are caught in the rapid arm race of the AI industry. Question is not whether AI will reshape technology as we know it, but what extents it will influence clinical practice, medical research, and education. Harnessing AI for health and reducing digital gaps. AI is already playing a role in diagnosis and critical care, drug development, disease surveillance, outbreak response, and health system management. The future of education and health sector is digital. We must do what we can do to promote universal access to these innovations and prevent them from being another driver of inequality. WHEC, Women's Health and Education Center, is committed to developing and promoting sustainable models for the implementation of AI programs at the country level, making AI solution accessible and impactful across diverse healthcare systems. Within the realm of AI for health, WHEC's strategic approach centers around three pillars: enable standards, policies, governance, and guidance on health, evidence-based AI for health. Facilitate pooled investment and a global community of experts. Implement sustainable models of AI programs implementation at the country level. Now, these are the emerging uses of AI in health sector: drug development, outbreak prevention, cancer research, electronic medical records, tuberculosis program, traditional medicine research, personalized health plan, genetics, virtual healthcare, mental health, and much, much more. ChatGPT, which is used in healthcare currently, is a linguistic model rather than a search engine. So questions posed in natural language yield more helpful results. Promises and pitfalls of AI in health sector. This discussion is based on the review of medical literature and an overview of ChatGPT, its usage in healthcare, and its release in November 2022. By February 2024, it has become the fastest growing consumer application of AI. We must remember AI is a tool and it is very much under human control. Medical queries. AI's accuracy has been proven for ophthalmology, hepatic disease, oncology, and obstetrics and gynecology. Limitations: a static knowledge base and lack of specificity. It will not include any research or clinical updates published after September 2021. Therefore, Professional societies' guidelines remain essential cross references to ensure accuracy and appropriate use. Documentation and administrative tasks. AI has been very helpful in generating patients' clinical letters, radiology reports, medical notes, and discharge summaries, prescriptions refill, and scheduling appointments. Limitations: AI cannot handle sensitive patient information and potential risk of data breach and privacy concern. Clinical decisions and support. Limitation: AI cannot provide personalized insight into decision making. Now, the AI usage in health sector for medical education and research. Here is the summary of the usage. I will not go into details because Dr. Gopalakrishnan, who is on the panel and of the speakers today, will discuss in details. Bottom line is AI cannot and will never be able to replace human element in education. Human touch, which is so important in managing patients, will never be replaced by any technology. Now, bridging the gaps for AI-based digital health system to benefit people uniformly around the world, multiple important gaps needs to be addressed. These include robust governance, ethical considerations, and strong public trusts. Systems must be developed with regulatory guidelines that secure people from harm and avoid deepening social, economic, and ethnic disparities within the countries or in between the countries. WHEC welcomes UN partners to join the Global AI Initiative to address actors' fragmentation and work towards a better coordinated governance of AI for health. Least developed countries are the world's greatest untapped resource, whose needs must be addressed to achieve the sustainable developmental goals. One out of every three of 2.7 billion who remain unconnected to the internet live in these 46 least developed countries. Halfway through the decade of action on the UN SDGs, these countries face daunting challenges. Together, let's make 2024 a year of progress for digital transformation in the least developed countries. Now, in summary, better technology means less hassle for patients and healthcare workers. Artificial intelligence offers an opportunity to complement workers' skills and expertise if we direct its development accordingly. For AI-based digital health system to benefit people equitably around the world, multiple important gaps needs to be addressed. These include good governance, ethical considerations, and strong public trust. A multi-agency global initiative for AI for health is warranted to improve coordination, leverage, and individual agency capacity and ensure that the evolution of AI steers away from a wonderful future towards one that is safe, secure, and trustworthy and equitable. Ultimately, the AI revolution is here to stay and will likely continue to surprise us in ways we could not even imagine. In fact, it is now opening interesting perspectives in terms of human AI collaboration and future jobs such as AI whisperer or AI prompt engineers that in a few years ago would have seemed taken out of sci-fi novel. By integrating AI tools rather than trying to ban them, educational institutions will be able to optimize their use, mitigate their shortcomings, and hopefully reap the benefits of this unprecedented, disruptive, or useful technological revolution. please feel free to contact me. This is my email address. And thank you very much. Okay. All right. Okay. Thank you. Now it is my indeed a pleasure to give the floor to Dr. Roger Worthington, consultant in ethics and global health. Miss Minchi Kang from South Korea, if she joins us, a brilliant youth leader, and Dr. Colleen Kraft, 2018 President of American Academy of Pediatrics, and Mr. Arthur Mangwada, Assistant Lecturer in Computer Science, addressing Internet of Things. Go ahead, guys.
Thank you very much, Rita, for the introduction, and it's a pleasure to be here, and I look forward to working with members of the team for the next half an hour, roughly. I was going to start by having a discussion with this youth leader who's a student of mine. She's been working with me now for a couple of years, but sadly it's 2 in the morning in Seoul, and so I think she has succumbed to natural instincts and not being able to make it today. So I'm going to now share my screen and start with the presentations. And so we'll now take it from the top. So I'm going to start off by talking about AI in terms of ethics and the SDGs, both of which Rita very helpfully referred to in her introduction. And so I think you already know the cast list for this. So I will go first, then hand over to Colleen, and then Arthur will follow with some case examples from Malawi. I do a lot of work in relation to the Sustainable Development Goals, and so I just wanted to flag this up at the beginning. So I'm going to address aspects of SDG 3, 4, 10, 16, and 17. And of course, we're discussing AI in healthcare, ethics, and potential uses in relation to promoting the Sustainable Development Goals. So we're familiar with this. So 3, 4, 10, 16, and 17 are the ones I will refer to in this talk. So in terms of new technologies, it has long been the case that new technologies present challenges and opportunities in equal quantities. I mean, I remember not that many years ago, well, possibly a while back, but when IVF first became a reality, there was lots of hype. Some of it was based on well-founded concerns. Some of it perhaps less so, and we've learned to live with it and to produce some sort of regulatory or ethical framework, although it does depend on which part of the world you're in. So that we've got used to. The Human Genome Project came after that, and that similarly raised a number of concerns, but had tremendous potential. So, but I think it's worth stating that the technology itself cannot have moral agency. It just does not work that way. It's the humans that design it and then employ it. They are the moral agents. So we mustn't expect the technology, even AI, to sort of assume properties that it doesn't have. So as we've already heard, there are both positive and negative consequences associated with using AI, which in clinical terms we tend to refer to as risks and benefits. So I ask the rhetorical question, really, whether AI is qualitatively or quantitatively different from other emerging technologies. And I think the answer to that is probably yes. And we'll hopefully during the course of this session explore some of the reasons for that. So we've already heard that the applications are numerous, with many more that are still to be identified. And often there's a delay between an emerging technology and it being applied in clinical practice. And we've already had some examples. I just flagged up a few here. Certainly enormous potential in terms of radiology, where it can diagnose with considerable accuracy and save time and reduce costs. Pharmacology, again, Rita mentioned this in terms of trawling data, helping develop new drugs and with prescribing and so forth. And I also just mentioned medical education because it exponentially increases the range and the scope of information that is available to the student. Whether the students, to the extent to which they welcome that, I suppose could be a challenge because the expectations can rise in equal quantities. But of course, nobody expects a clinician these days to have all that knowledge at their fingertips, and it's perfectly normal for the doctor to get out their smartphone and look something up even in the middle of a consultation. So these things have changed considerably in recent years. So let's think about the ethics now and some of the pitfalls that users and policymakers need to think about. And the first one, which does concern me greatly, is the question of replicating existing biases. This is a very real and genuine concern, because what AI is doing is scraping information from existing databases. And because of my work through the SCG Publishers Compact, I'm very mindful that the literature, the academic literature, tends to be very biased in terms of English language. It is biased against cultural and ethnic minorities and developing countries who sometimes have less opportunity for getting their work published and known and recognized and indexed. And so at present, the AI technologies really do not have the tools to address these biases. And so it has the tendency to exacerbate current inequalities. So I think it's important to mention this without wishing to take away from the potential. We must be mindful that this bias is inherent in the system as it currently operates. And of course, there are other concerns which are perhaps more to the fore about privacy, confidentiality, data storage, and the lawyers are already busy arguing about the ownership of some of the material and copyright issues. I'm not an expert on that, and I will not go into that, but certainly privacy and confidentiality are well-known ethical concerns in medicine, and that applies to AI as well. So this is my sort of health warning, if you like. So to ensure that AI is used to promote health, well-being, and education for all, in other words, trying to fulfill the goals, SDG goals 3 and 4, we must consider both sides of the equation and not wait until the problems are insurmountable. There's always a time lag between the introduction of a new technology and the frameworks that might be used to regulate it or legislate on it. And the pace of change is so rapid with AI that if we don't act as a society, we, in the broader sense of the term, if we don't act to address some of these concerns, it may be too late to to rein it in. Now, Rita was referring to chatbots, but I found an article just last week, which I thought was worth referring to. And its heading was, your AI therapist, and I was a chatbot, is not your therapist. And just this quote, which I think is worth looking at. So current physical and financial barriers to accessing care, people with mental health conditions may turn to AI-powered chatbots for relief. However, it's easy to overestimate the therapeutic potentials and so forth. So it's just a little bit of warning there, because it can be, it draws you in, these chatbots, into a conversation, but the therapeutic potential is possibly not, it's easy to exaggerate that. Just a few other references I want to include. There's an article in the British Medical Journal about amplifying disinformation. And as we're all aware, there's no limit to the amount of disinformation that is available in the world. And there are people who are actively promoting that for their own ends, whatever they may be. And so we need to be mindful of that in the context of AI, because it can amplify the disinformation as well as the positive, useful information. So yes, there will be bad actors who try and use it in ways that do not benefit others. And that applies to all users of the internet. So that problem is not new, but perhaps it is amplified. But there is potential for using AI to promote the SDGs. I provide a link there, but I don't really want to follow that now. It's just if anybody accesses the slides later, there's an article there that I reference. But I will go on to talk a little bit about the SDGs. And I think, as Rita's already indicated, AI can particularly be used to help low and middle income countries in terms of accessing research and resources that might otherwise be out of reach. Of course, that is prefaced on the fact that they need to have access to the internet in the first instance. But I put my caveat in here because there are gatekeepers to this knowledge, and that includes academic publishers as well as academic institutions. And those gatekeepers need to use their power and influence to good effect. Otherwise, as I already mentioned, it can act to increase the discrimination and biases within the system. And in terms of labor, much discussion is in the media about AI replacing humans. And of course, it can be used to employ tasks that don't have to be done by humans. I mean, I was referring to radiology, and they can scan masses and masses of data and come up with a diagnosis in a fraction of the time that a human. But this only works if and only if there is adequate human oversight and control. So that is my sort of mantra, if you like, for this talk. It's about if and only if. It's how we use it, how we apply it, how we build frameworks around it. So it is not the Wild West. So sticking with the SDGs, 16, which is about peace, justice, and strong institutions, I think AI increases the need for institutions, and I include law in that, to help guard against risks, and to try and ensure that AI is properly applied. And in terms of partnerships for the goals, I think organizations that particularly those that sort of cross boundaries, whether it's international boundaries, intellectual boundaries, or both, AI can help to democratize information at scale by making it available and helping to the work of some of these partnerships. So the potential is certainly there. So to conclude my part, I fully recognize the potential, but we do need to keep our feet on the ground and think about the positive as well as the negative. And it could, perhaps should, help to promote the SDGs, but there's my caveat, if and only if we remain vigilant. And I make no apologies for the emphasis at the end. But thank you for listening. And I'm now going to hand over, I'm going to continue with the slides and hand over to my friend Colleen Craft, who will take us through the next step. Colleen.
And really looking to kind of crystallize the whole conversation here about AI and what's happened with decision support. And I'm looking specifically at pediatrics. On to the next slide. Because we still, even in high-income countries, have gaps in diagnosis, and even worse in low-income countries, in areas like developmental disabilities, genetic phenotypes, some of the imaging that we do, and in things like risk of sepsis. Next slide. We have gaps in treatment in things like glucose monitoring and diabetes, in our medication shortages, and in hemoglobinopathies. Next slide. And then we have gaps in self-management. What about cognitive behavioral therapy tools, or sleep efficacy, or remote monitoring for pulse or oxygen or heart rate? So next slide. This is really where the role of artificial intelligence can come in, and you can keep clicking. So it's really using computers and statistics to help to solve problems, make predictions, make automated decisions for tasks that typically have been done by humans, but humans can take this information and speed up the time it takes to actually make a clinical decision. Next slide. And this is really looking at the different types of machine learning. Supervised learning is when that algorithm gives you an output. You have something, you don't have something. And it's used right now in image classification and customer retention and diagnostics. So this is really the big area where we've seen a lot of pediatric devices work. Reinforcement learning, I'm going to talk a little bit about this. This is where you do something, and if you get better at it, you go up to a bigger level. And we're seeing this now in the surgical fields. Unsupervised learning is something that is coming along, and this is really where we get data that may be somewhat disparate together that actually gives us information that we would not have known otherwise. Let's go on to the next slide. Deep learning is part of that machine learning algorithm that takes that unsupervised learning, and within what the data can combine, can actually develop relationships within networks of data that can give you some really great information that you would not have known otherwise. So next slide will give you a good example of this. Let's look at deep learning an image of a face. So the image of a person can be recognized through simpler concepts such as corners and contours. But deep learning will help to put those different algorithms together and have that different learning so that there can be some identification that happens because of this. Let me give you a very, very crisp solution here. Let's look at a very complex algorithm. So we are looking at a child on one side who has got typical facies and a child on the other side who has the facies of a child with Down syndrome or trisomy 21. Next slide. What some of these algorithms are doing are putting together those complex facial features of a child with Down syndrome. So what goes into that algorithm in the decision tree? They look at epicanthal folds, upslanting palpebral fissures, flattened nasal bridges, low set smaller ears, a smaller mouth. And it's not just identifying these, but it's identifying if a child has one of these features. Do they have two of them? Do they have three of them? And the more features this child has, the more likely they are to have that algorithm come up with that supervised learning result saying, oh, this child has Down syndrome. And that's where more data into this, the more pictures of children with Down syndrome the algorithm gets, the better that algorithm is trained to be very specific in taking care of this child and identifying, do they have Down syndrome or not? Next slide. This is how it works. When the algorithm sees these different pieces together and interrelating, we see that child with Down syndrome, the algorithm sees a child with Down syndrome. Next slide. When that algorithm puts the things together and says, no, this is not a child with these different features together, the algorithm sees a typical child and we see a typical child. Next slide. This is actually a thing. There is an app called Face2Gene, which uses deep learning and computer vision to take a picture of a child and then relate it to many different phenotypes that are out there. So think about this in a low resource country. You have a child that has what looks like a few dysmorphic features. You can use Face2Gene and identify that this child might actually have Down syndrome, or this child might have another different syndrome that is out there because of the different supervised learning techniques that are put into the algorithm for this particular product. Next slide. Another area where we're using this globally is in pediatric vision screeners. This is a picture of a child who looks like they may have strabismus or they may be cross-eyed. But in many young children, if you look at the inside of the eyes, they are asymmetric, and often that gives the appearance of that child having cross eyes or strabismus, where they may not. In days past, this child would have had to see an ophthalmologist to have an exam to see if they had strabismus or not. But the pediatric vision screeners are very good at telling us whether these eyes are aligned or not. And it really, in very low resource settings, it can really define which kids actually need to see an eye doctor and who doesn't. In high resource settings, we actually use this as a screener now with our well visits, because we can define up to 6 months of age if a child is already going to have signs of strabismus or lazy eye and whether they need to actually see an ophthalmologist. Next slide. Pediatric robotic surgery. Again, this is that responsive learning. This is the better you get at something, the more you can do a more specific task. This will help us with a child who might have a tumor and really identifying where that biopsy has to occur, or a child that may have a lesion that needs to be removed very, very carefully. And this can pinpoint where exactly that lesion is so that you have decreased morbidity. Next slide. Wearable technology, really important in monitoring for kids with medical complexity. Real-time notification during health emergencies. When is that child's heart rate going too high or their oxygen going too low? This again is part of that supervised learning. Next slide. And then mental health technology. We talked about chatbots. Both Roger and Rita talked about chatbots. And where chatbots are not your therapist, what the mental health technology is doing is using this to help to review and refine and go over some of the techniques that a child or an adolescent might use in something like cognitive behavioral therapy. They're not with the therapist, but the chatbot helps them with, I'm feeling anxious. Where do I go? What do I do? How do I breathe? How do I think? And this is really a great self-management tool. Next slide. This is a very interesting thing. When we look at discovery and visualization of structural biomarkers using machine learning, we know that 1 in 10 people develop knee osteoarthritis, which can't be detected right now until the damage has occurred. Next slide. But using AI within scans, you can look to see if there is, by water patterns, if there's any osteoarthritis or not. So next slide. What the algorithm sees and the doctor doesn't, you can keep clicking on this one here as well too, is the diffusion of water. And in water that's evenly distributed throughout the cartilage is something that is a normal knee. Pooling of water at the center of the cartilage suggests that there's a weakening. And this specifically is going to tell you who's going to develop osteoarthritis in the next few years. Next slide. What if we could continue to do this for other diseases? What if we could apply this technique to autism, to schizophrenia, to Alzheimer's disease? Can we identify and halt these things before they even begin? Just like when the first image was taken, the face of medicine is about to change again, because we can begin to see the invisible through AI. Next slide. We need continued advocacy here. You need the infrastructure necessary for the technology to work. You need to address the digital divide. If you don't have the infrastructure and the Wi-Fi, a lot of times you can't get to the data. Where there is insurance coverage for new devices, that needs to happen. These can't be so expensive that we can't use them. And there still needs to be for children a caring adult in a medical home. And with that, I will say thank you. Interpretation and clinical context again, too, is that everything that it comes through AI still needs to be modified through a clinician.
Thank you very much, Colleen.
Yes.
Much appreciated. So Arthur, would you like to take over from here? And I will click for you.
Arthur, we can't hear you.
Maybe you're muted, Arthur.
Oh, thank you very much. My name is Dr. Manon Daziloja introduced, and thank you very much for your better introduction in AI, and Colleen has explained much on it. So I will be taking you through your application of AI in the health sector in Malawi, a case study of tuberculosis, chest X-ray image classification. Next, please. Next slide. Yeah, as we know, tuberculosis is a major public health problem here in Malawi, as well to the world. And in this presentation, I'll take you through the current status of tuberculosis, as well as AI adoption in healthcare in Malawi, and the potential of AI for tuberculosis diagnosis, as well as ethical consideration and the way forward for Malawi. Thank you. Then take the next slide. Yeah, and tuberculosis, as we can see in the global, mostly these are the countries which are facing most of this problem. And if you see, most of the countries which are most affected have got low income countries, including Malawi is included in it. And in Malawi, only in 2022, they recorded almost 10.6 million people who are having this problem of tuberculosis. And this report, we've been like people like in 2020, earlier this year, most of this kind of tuberculosis are recording is like pulmonary tuberculosis, which are being affected by the lungs. So as we can see, we are facing this a lot because we don't know how, like most of the hospitals here in Malawi, most of the health centers, they don't have this kind of technology which they can use to diagnose and early diagnosis of this kind of tuberculosis. Next, please. Yeah, current status of tuberculosis here in Malawi currently. In 2020, Malawi, they recorded almost 59,000 new cases and relapse cases of tuberculosis. But in 2022, dropped a little bit to around 35,000. So this still more a problem, because this is happening most of the time. We don't find a proper technology to use, and we just know it, like even the crucial to how we can measure this kind of they can diagnose this kind of tuberculosis, but controlling at an early stage could be very good. But the challenges even include the access to the healthcare, especially in rural areas. As we know, Malawi is in the global south and is part of the low income countries. Next, please. Yeah, so AI adoption now, it comes in a process where in Malawi it's still at the early stage of the adoption, but there are different of application in healthcare, but inclusive specifically in tuberculosis, as it is being increasing. So Malawi Liverpool Wellcome Trust is one of the organizations here in Malawi responsible for most of the innovation, most of the technology, implementing technologies into health sector. So currently they have developed this kind of chest X-ray diagnosis using the AI. Mostly, as a part of the project, we used deep learning, as Colin said. Deep learning, it's the more you train the model, the more you give the data to the machine, to the model, it's the more they learn the pattern on how they can diagnose that, whether this tuberculosis, with this picture of the X-ray, have got tuberculosis or not. So we use the algorithm. The algorithm is part, as Lita said, it's a part of the which we use, most of the algorithm which we use. So the most of the algorithm which we were using, we used convolutional neural network, which help us now to really track what kind of part of that to come up with the different kind of features which will determine this particular X-ray machine, X-ray image. I've got tuberculosis, which is this not, and it's really important to classify. But the more that's where we say, even at the AI, most of the people, they might hate that AI is not bad, but it's like it's the design. It's what you give to the machine is what you get. So the more they clear the data which we give to the machine, that's where when we are using it, it will get the better results. So it will learn from the patterns from whatever the data which we are giving. So like we were using the images, set X-ray image, chest X-rays images. So this part, the most recommended algorithm is convolutional neural network. So it's much better to identify the pattern and the features in the tuberculosis X-ray machine so that it will be able to classify between the two. Next, please. So I think I just didn't include there, but we use the data set from Malawi as well as from outside. So the more we give, we might use the different kind of data set. Before going here, we might use different kind of data set, but they are also kind of the way of some kind of ethical as it comes to the data. So the more we give the data, also we have to consider now the data privacy of the people, so that as long as we train the model for the artificial intelligence, we need to consider also it's not to reveal the privacy of that until maybe we are given those kind of authorization to go. So the data set which we are working on, it was a public data set first, which was just publicly available for the tuberculosis, but here in Malawi, it was being regulated by Public Health Institute, PHR. So they were introduced and they were consulted for most of the patients which have been taken this kind of chest X-ray. So they implemented and we are able now to track, just because to diagnose, once we give the chest X-ray images to the system, it will able to categorize. Now, these are the tuberculosis image, and this one tuberculosis. In one way or another, it really helps. We had this kind of scenario where my cousin had like the pulmonary problem in the lungs, but because he was in the rural and there was few kind of technology being used in those kind of rural health centers, they said you are tuberculosis, so they started to give them the medication for tuberculosis, but she was not suffering from tuberculosis. So they found out later on, after now diagnosing with the tuberculosis in the other health cares, which really prompted me now to enter into this kind of AI. So that's why they use this kind of technology to know, no, you are giving a long medication to a long to the long disease which was being diagnosed in that way. I know, like, my people, they might be trained in this, but they might be totally different, and they may be totally clear that this, it might be tuberculosis, this might be I mean pneumonia, which will affected. So coming in with an AI, the more the data which is labeled by the radiologist, they could be really better to train the model and to do that kind of work, and to really help those kind of radiologists to classify the images of tuberculosis. So it's really making. So the way forward, embracing the AI for healthier Malawi, we really need to invest and develop the healthcare application. So not only we can apply this kind of in chest X-ray, but we can build also into different kind of application, whether into the people who have got sound problem, like the eye vision problem, the audiology. We can totally embrace this kind of, and with the coming of now, like the natural language processing, we might also use the same kind of AI to use now to track, which is the bad words, which even really affect people mentally, and it could really help to track that. And it's also really important as long as we are training this kind of model, that's what I said, the garbage in is the garbage out. Once we give the long information, long data set, it will really bring back, but we needed to consider also the ethical concerns around the data which we are trying, also the bias of the AI algorithm which we are trying to use. So ensure also equitable access to AI-powered healthcare services. We really also want to embrace in Malawi that particular AI in Marathon. Next, please. So take away messages which we might really try to put is tuberculosis remains a major public health concern in Malawi, not in Malawi, but in most low-income countries in the world. But AI has come to revolutionize, like to change most of the way of doing. It's not to come to replace the work which we are doing, but really to help to improve the way on how we handle different problem, or how to diagnose, even treat most of the diseases in the hospitals. So Malawi is taking this initial step, but adopting the artificial intelligence in healthcare, we really need also to consider, while we are adopting, we really need to consider this kind of ethical consideration and ensure equitable access to all people in healthcare, and as well as we need to embrace, we need to deal with the ESCO as well. It should be starting from now correcting the data. When we correct the data, we should be given now like a go ahead from the owner of the data set, as well as when we are using this, it should not be that bias that may be giving wrong information to wrong people, which might also affect the patients in the hospitals. Next, please. So these are some of the references where we got some of the statistics, and thank you very much for your listening.
Thank you, Arthur, very much. So back to you, Rita.
Thank you, Arthur and Roger and the whole entire group. Now it's indeed my pleasure to hand over to Dr. Vanati Gopalakrishnan, Associate Professor at University of Pittsburgh, Pennsylvania. And go ahead, Vanati, it's all yours.
All right. Can you see my slides and hear me?
Yes, yes.
Great, thank you. Yeah, thank you so much. Good afternoon, everybody. And thank you, Rita and the WHEC for inviting me to present this talk. As Rita said, my name is Vanati Gopalakrishnan, and I'm a tenured associate professor in the Department of Biomedical Informatics at the University of Pittsburgh. AI in medical research and education has become a hot topic these days. And today I present a snippet view from directing my probe laboratory for pattern recognition from biomedical evidence for the past 2 decades. So our probe lab's mission is to accelerate biomedical knowledge discovery by developing and applying hybrid rule learning methodologies that can learn predictive models from prior knowledge and diverse types of biomedical data, both structured and unstructured, such as from lab measurements, imaging, and clinical notes. We've developed and applied explainable AI, such as the Bayesian rule learning, BRL, or transfer rule learner, TRL, to predict from biomarker data. I think Colleen and had already explained what these types of biomarkers are, especially from imaging data. But from high throughput studies, you can actually measure like hundreds of thousands of genes and proteins and so on. So I'll show you some snippets of those. But basically, if you have a bunch of biomarker data, you can then apply machine learning algorithms and learn explainable predictive models that are of the form of like if condition, then class, which refers to the kinds of supervised methodologies that Colleen discussed earlier. And along with them, you can learn what is the uncertainty in their validity. That is such as like, what is the posterior probability of these types of patterns that you can learn from rules? And you can try to predict mechanisms of action, target selection, useful biomarkers for early detection or monitoring of disease, and so on. I recently served as the elected director of a unique multidisciplinary applied AI graduate program at the University of Pittsburgh called the ISP, or the Intelligent Systems Program. And here you can see that it's basically a program that has a set of faculty that come from various departments, in this case, about 14 odd departments from across the university. And IS refers to information science, computer science, computational systems biology, psychology, law, and so on and so forth, including education and political science. And you can see here that DBMI, which was the Department of Biomedical Informatics faculty, comprised almost more than a third. And we had an area of concentration in medical informatics within the, so that we could tie together the School of Computing and Information faculty and also with the School of Medicine faculty and so on. And this really gives a very good kind of platform for interdisciplinary research. It's a graduate program in applied AI. As I was doing this role, as I was performing this role, I realized that there was no real consensus for what constitutes intelligence. And so I figured that if you want to define artificial intelligence accurately, you probably need to first have a good understanding of what intelligence really is. And so this gave me a bold idea, which is that I could actually come up with a novel definition for intelligence. So I described intelligence as clear thinking aligned with natural laws, using multidimensional, multimodal perception that is transformed into decisions of when and how to act. And this was defined from an agent perspective, and it was published in the AI magazine by Ganesh Mani, who's going to be the next speaker, who will speak to you now on a different subject, economy and society. And his article was entitled Artificial Intelligence's Grand Challenges, Past, Present, and Future. So I think this definition sets a much higher bar for artificial general intelligence. And so if this sparked off a whole lot of research in multimodal AI, you can blame me for it partially. So big data and biomedicine is what this particular slide shows you. And you have two different types of big data. You can basically say it's omic driven, which is these high throughput gene expression, proteomic expression, next generation sequencing, and so on, these types of data. And EHR driven, which is electronic health record driven, where you can also put in the radiological images, medication history, allergies. And if you look at that, that looks very temporal in nature. So I wanted to show you this to show you that it's actually quite complicated for AI predictive algorithms to actually develop models. And so this is important to show. And as we head towards value-based healthcare, we need to know what are the sources of big data in healthcare and what kinds of applications they serve, just so that you have an idea of where the errors are coming in and where really are government agencies playing a role, where are the research studies happening, what is the source of these data, so that you can actually then be able to understand how to evaluate the models that are coming out of artificial intelligence. Rita alluded to some of that earlier. So to show you the multimodal data in biomedicine, and I wanted to show you on the left side, you can see that the data for electronic health records has two types of elements. One is the set of structured data elements, which has the ICD codes, demographics, and so on. And we have unstructured data elements that could be images, graphics, radiology reports, chief complaints, discharge summaries. And natural language processing, also known as NLP, is a big topic in AI. And that is typically used in medicine to create these structured data elements that are then used as secondary purposes for doing predictive models. On the right side here, you can see a very well-referenced paper by Acosta et al., which came out in Nature Medicine, on multimodal biomedical AI. And you can see so many different data modalities like omics, metabolites, immune status, microbiome, EHR scans, wearable sensors, ambient sensors, environment, all playing a role, with many opportunities for AI, including hospital at home, precision health, digital twins, pandemic surveillance, and the virtual health coach. I wanted to present this slide to you so that you can take a look at it, anybody who's researching this area. This came out, I think, yesterday or day before. Most recent preprint from Google Research and Google DeepMind. And Google DeepMind, as you know, is very heavily involved in creating the AlphaFold, which was trying to solve some of the major problems in computational biology. And this gives you an idea of how they have advanced multimodal medical capabilities of Gemini or MedGemini, using like 2D images, 3D images, and gene, and a whole bunch of applications, including question answering, report generation, genomic disease prediction, and classification. So a few emerging AI technology areas include digital twins, multimodal large language models, and collective intelligence. And this slide shows you many fundamental issues that underlie AI technology creation, including knowledge representation and reasoning, how do you do data collection and pre-processing for machine learning, and model representation and parameterization. And I'll come to how many people are using deep neural networks, but they are typically good for vision, image processing kind of applications, but not that explainable, if you will. So as Roger alluded to it, we really need explainable AI so that you can understand what's happening and it's not a black box. And simulation of data and processes are very, very useful for educational technology. I'll show an example in the future. So our core probe lab research mission was to design and build intelligent systems to reduce the burden of disease. And we've been working with human in the loop. And we want to create predictive models that are human interpretable. And in the future, we want to do integrative model development and build capabilities for multimodal intelligence, which includes vision, language understanding, text, and Internet of Things into the agent design. And also focus on creating virtual reality environments for training AI human teams, so man-machine teams. And this is the kind of data that we've analyzed, going on from proteomic, which are very large data sets, to smaller immunoassay validation data sets, genomic data sets, including small nucleotide polymorphisms, and then images, including cardiac MRI, brain fMRI, which is 4-dimensional, microbiome, metabolome, exposome, federated EHRs. And we've applied these to the biomarker discovery studies for early detection of neurodegenerative diseases, different types of cancers, inflammatory bowel diseases, coronary artery disease, pediatric cardiomyopathy, and all the way down to doing spinal aging. So to give you an idea of the kinds of innovative algorithms, AI algorithms we use, one of them is called Transfer Rule Learner, which was the first application of transfer learning to biomarker discovery. And this was taking care of the problems associated with very little data. So people keep saying that we have a lot of data and so on. But when you actually go down to the nitty-gritty and try to do precision medicine and personalized medicine, the data keeps getting subsetted down until it's very little. And so we call that the sparse data problem. And we needed to figure out how we can learn from multiple institutions' data so that we can actually augment the data and have better evidence so that you can actually perform good prediction and learn generalizable models. So here's an example of another example where we used lung cancer early detection, where we devised a blood test, which could be combined with clinical history and CT screening results to be able to improve the accuracy of early detection of lung cancer. Other example projects that we have looked at include biomarker or pathway discovery from metabolomic data for personalizing heart disease treatment, and applying these to microbiome data, the transfer learning, doing IHEAL informed health through eating awareness learning, where you could potentially combine nutrition science with behavioral research and machine learning. This is not yet done, but I will show you how we could potentially do that if we could have, to bring about some equity, if we could do language learning from multiple languages that are local languages, if you will. And then, aggregate data collection from federated electronic health records, which are actually not even in place in many of the low research settings. And people are talking about bringing these about. And I think that would need a concerted effort to make sure that you don't spend that much money to do this by taking charge of how you do digitization in a better way. I do not know the answers to those questions, but these are things that we can collectively come up with answers to. Here's an example of metabolomic study of CVD that finds very interesting things like, for example, if you look at the data, you will be able to identify something like gender-specific metabolites that indicate that early balding in men seriously escalates their risk for CVD, much higher than that of obesity. So you could come up with innovative applications of these, such as coronary artery disease intelligent detection via metabolomic expression, or CAD-ID-ME, where the question is, can you identify early atherosclerosis or blockages that could potentially be harmful in patients? And to do so, one would need to actually create a knowledge base of cardiovascular disease risk factors and create a personalized risk score from that. And this would be a very massive undertaking in order to do that across to be able to personalize this for every person on the globe. So to summarize, we have like in AI in medical research, you can have drug discovery and development, you can have genomic analysis and personalized medicine, you can have medical imaging analysis for disease diagnosis. And these are some of the various places in which we have actually done research and found useful patterns, if you will, and translated some of these knowledge for benefits of AI in medical research, these include accelerating the pace of discovery, identifying novel insights from large data sets, and enhancing reproducibility and reliability of research findings. Within the education side of things, you can have virtual reality simulations for surgical training. And these, you can also have adaptive learning platforms for personalized learning, which many people are doing. Here's an example of a slide from Dr. Sunish Menon. He's actually applied for a position in my laboratory, but was kind enough to create this. His thesis actually used augmented reality in nursing education. So it shows you how you can like sort of do this placement of anatomy on top of a real patient or a cadaver, and it actually helps in terms of medical education, especially in nursing and medicine, where it leads to improved learning, memory retention, and knowledge gained. And this is just to give you a small snippet of these types of applications. But in summary, I'd first of all like to thank ChatGPT and Claude.ai, which actually helped me come up with some of these talking points. And I'd like to conclude by saying that there are challenges and ethical considerations that include data privacy, security, which needs to be addressed as things move across the globe. Ensuring transparency and interpretability of AI algorithms, mitigating biases in AI models that could impact patient care, and ethical implications of AI in decision-making processes. And I have a link here to some frameworks for good AI in society, which includes looking at beneficence, non-maleficence, autonomy, justice, and explicability. Potential directions include going towards multimodal large language models and Gen AI with foundation models that promote diversity, equity, and inclusion via digital health apps and platforms. As I was saying, there is Hanuman.ai and many other platforms that are coming about in India, for example, that can try to give you foundation models for different languages. And especially in countries like India, where they have maybe like they need 22 different languages. And this would really help in terms of communicating even with patient to medical professionals to patient communications. It would really help if there was this kind of easy to use platforms that can communicate in the language that the patient is most comfortable with. There are opportunities for interdisciplinary collaboration between AI researchers, medical professionals, and educators. For example, interdisciplinary science and engineering degrees are starting everywhere now, and this should soon become a norm, which is a good thing, because then AI can become sort of ubiquitous and integrated into these programs at an early stage. We have our own Hillman Academy high school summer programs, which we initiated in the University of Pittsburgh, which is one of the top 100 innovative programs. It was started off as a volunteer teaching to rising juniors and seniors. And very importantly, we need continuous evaluation and refinement of AI systems in healthcare and education. These are pretty much called learning health systems. You should be able to look it up. And learning health systems were actually created as a concept by which people who are all the multiple stakeholders can be part of the system and be involved in design and in the evaluation and in taking whatever knowledge is found from medical research, such as the ones I communicated from my laboratory, for example, like biomarker discovery and so on, and translate those findings and close the loop and make sure that everybody is involved in the loop in order to create this well-oiled system, if you will, that incorporates AI. Thank you so much for your attention, and happy to answer any questions.
Well, thank you very much. Now we have Dr. Ganesh Mani, assistant professor at Carnegie Mellon University in Pittsburgh. And his topic is AI in economy and society. Go ahead, Ganesh.
Thank you so much, Rita, for the opportunity. Wanted to say who I am, what I'm going to talk about. AI, economy, and society. If you see the Venn diagram on the left-hand side, it looks like there's modest overlap, but that overlap is growing. So AI and data are going to have significant influence on society and the economy. I'm with Carnegie Mellon. I'm not a career teacher, but last couple of years I've been teaching classes in AI and emerging economies. Did a workshop around AI in K-12. We also have a department primarily in the business school, Tepper, but there's this S3D, which is the software and societal systems department in the School of Computer Science, very germane to today's topic here. There's my Twitter handle. Through that, you'll be able to get to my email. But I talk about three different spheres: health, wealth, and wisdom, right? A lot of the economists are saying AI is changing careers, changing jobs. 85% of the job descriptions today are very different from what they were 3-4 decades ago, but not really, right? If you look at the three broad spheres, people were working so that they could improve their health, wealth, and wisdom, or they could improve other people's health, wealth, and wisdom, right? So farmers, clinicians, educators, they've been sort of doing at a strategic level, at a top level, very similar kinds of jobs across the decades. It's just that the tactical element has changed. The tools have changed, if you will. So a few vignettes here, obviously, bottom left-hand side, you see that life expectancy continues to go up. It has obviously moderated a little bit because we have some bad habits potentially. One example is obesity. This is fresh off the press, if you will. I saw it in the Time Magazine digital version this morning. Vanity and I are actually headed to Japan next month, so it caught my attention. Order of magnitude difference, right? 42% Americans are obese, 4.5% of Japanese people are obese. This is an article talking about why Japan doesn't really need Ozempic, right? The GLP-1 class of drugs and so on. Likewise, maternal mortality, even more foundational in the sense there's huge leverage, right? So if you can make improvements there, not only is there benefit to the current generation, there's benefit to the next generation and beyond and so on. So that's sort of the health landscape, if you will. If you move right along here, let me see what we're doing with respect to wealth, right? So left-hand side from some Berkeley economists, income inequality. There's a site called Real-Time Inequalities, so they're actually now casting some of the data. So a couple of takeaways here. The red line is the real income growth of the top 10%, so continues to show steady growth. Obviously, had a bit of a blip during the pandemic, but the growth rate is healthy again, right? So back on the trend line, if you will, while the green is the bottom 50%, right? So they continue to struggle. It was already plateauing and then it dropped off. And you can see the bottom 50% having come back to the trend line. Trend line was flat anyway, but even there, so it's arguably starting to slope down a little bit, work to be done. Right-hand pane is more the global picture, incorporates a little bit more than GDP, Human Development Index, a combination of a few factors. You can see how the pandemic sort of knocked us globally off the trend line, right? So that's something to fix from sort of the wealth sphere. Thinking about the wisdom sphere, it's more about education, K-12 education, which is foundational, not only for this generation. If you have better education, your earning power goes up for this generation, but also the earning power goes up because you tend to have better goals for your kids, for your grandkids, and so on. So again, a lot of leverage. The green charts are some dated data, if you will, from 2015. Some of it is positive data in the sense Africa, parts of India, they don't collect data using the same meter, the PISA scores, if you will, but you can see there's still a lot of diversity, right? So Canada is dark green, China is dark green. There are some Northern European countries, there's Singapore, Vietnam, down under Australia, New Zealand, etc., which usually figure well both in terms of science proficiency, the left green pane, and math, the right green pane. But see what's happened again over the last few years, right? Pre and post pandemic, not only are there issues in Asia and Latin America and the global South, even developed countries like Iceland, Norway, Netherlands, and so on, and have shown some deficit. The only countries that seem to be doing well post-pandemic, Japan, South Korea, Singapore, Israel, very interesting. What's common among some of those countries? They're amongst the most with respect to digital penetration, with respect to digitally native people, right? So I think, again, that's foundational if you can get internet access there. I want to sort of switch back. I think this is an article Vanti referred to. We talked about AI past, present, and future. This was some home office writing during the pandemic. But one of the mantras we came up with was, how can AI help, right? It should be of the people, by the people, with machines, for the people, right? So here is a New Yorker cover, trying to get to that human-machine teaming in the spirit of Escher. But the important point is by the people with machines, right? You really want a human complement. I jokingly say human replica can be created by a couple of people in 9 months, right? But you really want something that allows you to team well, amplify your expertise, and so on. So that's where we need to pay attention to. We have put down some challenges potentially for researchers, for practitioners for this decade, because we were talking about some of the old challenges that Turing Award winner and a friend of ours, Professor Raj Reddy here at CMU had written. We took stock of what of those had been accomplished and what are some new challenges for the coming decade with the quickening. So a lot of agent-related stuff, right? So if you can use a digital agent behind the scenes, a lot of things in the wealth sphere you can do without actually walking to the bank, without going to a big city. Likewise, health, Colleen talked about some very interesting telemedicine sort of applications, right? Diagnosing Downs or other things just based on one picture. Likewise, there's a great opportunity for education. Human touch is still important. In some cases, you either have to make do with technology-based education or no education, right? So there are a number of interesting agent-based things which can help you in the legal milieu. It can help you check whether something you get on WhatsApp, whether that information is for real or is that somebody trying to mislead you. Very important for democracy. Elections are coming up in the US. This is a paper again, a decade old, but very relevant by Emerita Professor Beverly Wolf from UMass and her collaborators. So they talked about how can AI and data be used in education? Can you have mentors for every learner sort of on tap, on demand? Can they learn 21st century skills? So skills are evolving, so your curriculum is not static, it's dynamic. Interaction data to support learning. So can you instrument it, right? Khan Academy or some of the newer testing is adaptive, right? Depending on what you get wrong, you may get a related easier question. If you get that correct, you get a more difficult, maybe unrelated question and so on. So, trying to make learning more efficient, universal access to global classrooms, learning Spanish from a native speaker, learning French from somebody who is immersed in France, learning Swahili from somebody who is immersed in Africa and so on. And obviously, almost like a bolt from the blue, we got LLMs, ChatGPT in the last couple of years, right? How can that be used? It's not a just add water kind of application because there are hallucinations, there are biases in the data. If you look at low resource languages, some of the conversation quality is very poor. And then I think Woody Allen used to say 80% of success, 80% of paraphrasing, imparting success is just showing up, right? So teacher presence, physical presence in the emerging economies tends to be important. Likewise, this chart actually from The Economist talks about teacher online presence, how that's correlated with improvement in those PISA scores that we looked at, right? So there's a little bit of a pattern here. USA, Israel, etc. Teachers are more present online, helping students when they have quote unquote doubts, if you will, as we say in India. So, what are some of the policy implications of this? Going back to sort of the wealth sphere, bottom left pane is a company, ICAD, which was doing one of the earliest second reader of mammograms. One of the first, was film scanned in, then look for abnormalities, calcifications, etc. One of the first FDA approved systems in the mid-late 90s. Deep Medicine is a book by Eric Topol, Rita, and Colleen alluded to some of the deep learning type of things. On the top left hand, you have, that's a little dated from 2021, all the FDA approved systems, right? You can see the top right is a more summary of that. The pink is all radiology, yellow is cardiovascular. So those have been the two modalities where a lot of these systems dominate. A lot of the others are emerging. And I think having more prospective studies, multi-center studies where you use federated data would be sort of the way to go. That improves efficacy, improves robustness, is more inclusive because you can get more diverse cohorts from Africa, Latin America, the stans, if you will, and parts of Asia and so on. Little tongue-in-cheek, there's a line saying, I have room for a second opinion, doctors beware. This is some brand new work. I think one of you was just talking about the learning health system, right? So can you use agents? So this is some work from one of the top universities in China, Tsinghua University, it's on archive. What they did is they simulated clinician agents with initial knowledge and then interacting with synthetic patients. So you can generate a lot of data on the fly, and then using reinforcement learning, which Colleen talked about, how they improve over time. So not only can this be used for clinical processes, it can be used for non-clinical processes, how to schedule resources, how to schedule the operating room, how to schedule nurses, who should be there when, what resource should be there, where, and so on. Top right-hand pane, mental health. This is a graphic from the recently concluded D3 Institute at Harvard webinar. Professor Amit Goldenberg from HBS posted this. So a lot of interesting applications of AI data with respect to mental health there. And bottom right here is a JAMA paper, which talks about, can chatbots be empathetic? Is the quality similar to physicians and so on? And surprisingly, the answer there was yes. If you can filter out, it was a smaller study, but if you can filter out hallucinations, there are a lot of things you can do by adding additional modules to chatbot output and so on, checking whether the responses are correct, forcing the chatbot to give you answers linked to trusted sources like Perplexity.ai is trying to do, right? They're trying to disintermediate Google search. Moving to sort of the wisdom or knowledge sphere. Let's face it, folks, privacy is dead, right? Fake media is here. We're hearing all evil, seeing all evil. People are, if you go on Twitter, there's a famous trial going on, a lot of things being posted on X, right? Formerly Twitter. Also, we used to talk about science being science, but science is also now machine science, right? So this is colleagues' work, PokerBot, that showed up on the cover of Science a few years ago, right? In the old days, it would be a new element or something, a new treatment. Those sort of things would show up on the cover of Science. So more game theory, more digital algorithms, and there's a whole new field of machine science or machine intelligence. How do machines behave, right? So I'm in the business school. In the old days, management science used to be about group human decision making. How do people get together in the boardroom, or how should people be making decisions in an enterprise for the benefit of other people in society, right? To bring that theme in. But now the future is multi-human, multi-machine, and we need to be thinking about what the domain of application is. Again, 3 spheres, if you will: atoms, bits, cells, right? So you can do a lot of modeling in the digital realm in bits to drive innovation in atoms and cells. In atoms, it's measured twice, cut once, right? So you have to be careful not to waste resources. And the cells milieu, you have ethical issues, you have, time it takes, be it to grow lab meat or for a CBT therapy to show results and so on. There's also, we talked about machine science. The science of science is a field, right? How should knowledge be structured? How do you recognize fake media? We had come up with the term mega journal when I was a grad student. Now there are a lot of mega journals. Can you link all the information so that you have one pyramid of trusted information? Maybe the lower quality information is at the base of the pyramid, can bubble up as bigger studies, as more. Vanity talked about linking Bayesian stats. So as more information, more evidence comes in, maybe things bubble up that knowledge pyramid, and can pyramids of knowledge be linked to other related pyramids and so on. And around the pandemic, there was a lot of information coming out quickly. People wanted to get that out, but that also had implications for quality. So we had put in some suggestions around best practices. Future of work is changing. This is 3 out of people use AI at work. I was shocked when I went to a large industrial company. I won't mention their name. There were 40 VPs there. only the CTO was using Gen AI was using GPT-4 or even GPT-3 because they were worried that they didn't want to use proprietary information in the chatbot. But I said, look, you're a public company. You could use marketing documents. You could use your competitors' information that you find on the web. But what we are hearing now is people are actually using AI at work. They're potentially putting in private and proprietary information they shouldn't be putting in. So we need policies at work. We need to make it easy for people to use AI at work. So there may be a clinician who's in a hurry in the ER, maybe entering some things for the benefit of the patient, right? But if there is a structured way to do it, if there's a way to protect private information and make sure what's coming out is trustworthy, it's not a hallucination, that would be good. Obviously, we also need to how law enforcement uses facial recognition, uses biometrics. Can you use brain scans because they have ethical implications as well? Can be used in a court of law. How should it be used or not used? AI and UN SDGs. This is by an acquaintance of mine, Ricardo Vinuesa, from Europe. People talk about I think it was Mark Andreessen who originally said it, software is eating the world. I say AI is heating the world, right? It requires large data centers, consumes a lot of electricity, all the benefits outweighing the costs and the deleterious effects and so on. This is some recent research on how can you use, Manti talked about collective intelligence, LLMs, and digital twins. This is combining LLMs and collective intelligence. If you have a group of 100 people and you want to sort of have them reach consensus, it gets very noisy, right? A town hall is raucous. But what if you put the 100 people in 10 rooms and then have an LLM monitor each room, but transmitting information that a room may be missing? So one of the rooms, they may be talking about cost, the other, they may be talking about impact. In the third room, they may be talking about regulation, policy implications. And so the yellow lines are the LLM transmitting information as needed. So this is some joint work with the Unanimous.ai people. They are doing swarm modeling, or they were doing swarm modeling originally. Now we have brought in the LLM element to it. So this can help build consensus in multiple milieus. This is my last slide. I think a lot of the AI production is happening in the West, big tech funded by the government. There's a stunning statistic that Sequoia put out that a lot of the new age AI companies, they've generated about 3 billion in revenues. But at the same time, the cost of infrastructure, they have paid 50 billion with a B to the cloud providers and to NVIDIA. A lot of that's gone to NVIDIA. So if you look at the amount of money these folks have to generate in revenue to make up for that, it's very interesting. But a lot of the use cases are going to be in emerging economies. Bulk of the users are going to be in emerging economies. So we need to co-design things, be it in the health, wealth, or wisdom sphere. I think open science is important. There's a big role for digital public goods. These are things that are widely available to everybody, trusted data, trusted methods, trusted protocols, if you will, right? Data, domain knowledge, as well as tools. AI is fire is a good metaphor, which is why we need bodies like the UN. We need maybe the World Economic Forum, or Singapore hosted some high-profile summit meetings, right, between then President Trump and the North Korean chief and so on. So can we have conferences like that around AI governance, how best practices can be shared, how data can be shared, so that we have international norms, collaborative platforms, and we can nudge consensus in the service of society. So that's sort of my summary. Once again, thank you, Rita, for this opportunity.
Well, thank you very much. Thank you all the panelists. Unfortunately, we have gone 5 minutes over time, but thank you our wonderful audience who have sent the questions. Mostly the questions were, can inequality in education and health sector be fixed in Africa or other low middle income countries with AI? If you have one last minute, one sentence answer to this, otherwise, please contact these speakers and panelists directly. Go ahead. Let's start from Vanati.
Yes, the one word answer is yes. And I think there's lots of tech going on in even Carnegie Mellon University. Africa is a good example of where a lot of technology is coming about.
Okay, thank you. Colleen, one sentence answer.
So I would say yes, with the new devices, if they are used by people to do some of the hard work and really provide that yes or no decision, they can actually be very helpful.
Ganesh.
No harm trying, right? We have to try.
We have to try. Okay, you are in maybe. Roger, what do you think?
I've nothing to add really to what other people have said, but we need to enormous potential, but we need to think about it in the round so that we think about both the positive and the negatives.
So Arthur, since you are in Africa, working in Malawi and making Malawi better, you have the last sentence and last word. Your speaker is, turn the speaker on.
Yes.
Okay, go ahead. You have a last sentence. Yeah.
Yes. There is possible, and most of people here now, they are coming up to with the use of AI and the application and different thing. As I said, as Vanessa said about, I was in Rwanda. I visited also Carnegie Mellon Rwanda, and most of people that are interested in the AI, and we had that kind of. I was there from University of Rwanda. We were collaborating hand in hand with them, and here in Malawi also we have this kind of group. So AI is here to even help and here to stay.
Okay.
Yes.
Well, thank you very much, and till we meet again. Thank you, guys.